All right, so now that we've learned how to look at a rhythm systematically, now we need to know, well, how do we figure out what rhythms are what? Well, we look at them systematically, but we have to know what the rhythms are in order to take that next step and figure out what we're going to do about them. So this PowerPoint is just to kind of break down some of the common basic rhythms that you might see in practice, and simplify kind of what you're looking at, take a look at it from a different angle. Keep in mind that if you gave a strip to 10 different doctors, they may all look at it and have a different interpretation of it. You're not expected to be practitioners. We're just trying to get you to be able to look at a basic rhythm and see the different parts of it and figure out what you might need to do about it. So let's start getting into what is normal. So let's first look at what is normal, because in order to understand a lot of abnormal rhythms, you have to know what normal is. So you can see that we're breaking everything down by P waves, regularity, QRS, and rate. These are all the things that we talked about in the last PowerPoint about how you're going to systematically look at these rhythms. So these are looking at them as a sum of their parts. So for normal sinus rhythm, we have P waves that are present. They're normal. So you have that small round hill before the pointy thing. That's your P wave. In normal sinus rhythm, they are present. They're normal. So they're that small round hill. And they're going to be upright. Regularity. So if you remember what regularity is, it's that distance between each heartbeat. And it should be regular. And in a normal sinus rhythm, it is regular. So that means each heartbeat is very predictable. So it's bum, 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 bum. It's going to, each beat is going to have the same distance between it. The QRS is present and skinny. So in a normal rhythm, that QRS or that pointy thing should be skinny. We're going to talk about later what happens when it's not. And then the rate's going to be normal, again, 60 to 100. So this establishes what is normal. In a normal rhythm, there should be P waves that are present, upright, that small little hill before the QRS. Normal rhythm should be regular, and a normal rhythm should have a present and skinny QRS and have a rate of 60 to 100 beats per minute. So let's see what we would do about normal sinus rhythm. So what are we going to do about it? Well, nothing. We're going to monitor this patient, maybe compare it with their baseline, see what their normal heart rate or rhythm is, but we're just going to watch them because there's nothing abnormal about this rhythm. There's nothing to treat. So let's start looking into some abnormals. So our first slightly abnormal rhythm is going to be sinus bradycardia. So if you had to name this rhythm, you could call it slow and skinny. You can see the P waves, again, are normal, present, so that small round hill right before the QRS. The regularity, again, is regular, it's normal. Every beat is at a steady pace. There's the same distance between each heartbeat. QRS is present and it's skinny. But look over here. What's different about this rhythm? It's the rate. So everything about this rhythm is normal except the rate. So it's normal, but just a little slow. So the rate's going to be less than 60 beats per minute. So what are we going to do for a patient in sinus bradycardia? Well, first we need to decide if they're stable or unstable. And how are we going to make that decision? Well, we need to see what's going on with the patient. First, we're going to look at them. What symptoms are they having? How are they feeling? What's their blood pressure? We're going to look at these things to see if they're stable. So if a patient's stable with a rhythm, their blood pressure is going to be normal. They're not going to be complaining of any symptoms. So if this is true for a patient with sinus bradycardia, we're going to monitor them. Compared to their baseline, we're going to ask them, hey, how slow is your heart rate normally? Is this your normal? And then we can maybe review some of the causes. What are some common causes of a slow heart rate? Well, if you take a medication that slows down your heart rate's going to be slow. So patients that are on beta blockers, they can have a slow heart rate. Also, those that are asleep or those that are super in shape, like athletes, can have a low heart rate, and that's normal for them. So what if the patient's not stable? So what if when we check their vital signs, their blood pressure was low? What if they were complaining of dizziness, lightheadedness, fatigue, shortness of breath, anything like that? Then we might consider giving them drugs or devices. So your drug choices are either atropine, which I remember atropine because it's TROP in the middle and it triples the rate of the pulse, or dopamine, which has PAM in the middle and it's the pulse acceleration machine. So you can use either of those drugs, or you can use a device, and the device we might use is a pacemaker. So a pacemaker can be used temporarily, or you can get a permanent pacemaker placed in order to speed up the heart. And this is a device that's going to force the heart to beat so many times per minute. And help to make sure that the heart is beating fast enough to get tissue perfusion. Because what's the problem with sinus bradycardia? Why do we care if the rhythm's a little slow? Well, if the rhythm is a little slow, if the heart rate is a little bit lower than normal, what happens is you're not getting cardiac output. If you only have, 4 beats per minute, that's less times that the heart has to get blood out to the rest of the body. If you're getting less blood out, you're getting less oxygen out, you're getting less perfusion to your tissue. So it all comes down to perfusion. So some people, their body may be adjusted to it. They can be stable with this rhythm. Other people, it's not going to work for them. Their body's going to say, no, I need more oxygen, I need more. So that's when we would use these drugs or a pacemaker. And if this is a rhythm they're going to be in long term, they may need that permanent pacemaker placed in order to keep their heart rate beating so much per minute. So let's look on the opposite spectrum. On the other end of things, there is sinus tachycardia, and if you had to name this rhythm, you could call it fast, skinny, and less than 150. So again, P waves present normal, so you have that small little round hill before the pointy thing. It's going to be regular, so there's the same distance between each beat. The QRS is going to be present and skinny. And then the rate, again, is going to be what's off. So everything is normal again, but the only thing that's off is it's fast. But you can see here when I'm saying fast, I'm saying it's greater than that normal heart rate. So it's going to be greater than 100. But you see here, it's also not more than 150 beats per minute. And this is an important distinction because we're going to talk about, this is a fast rhythm, but we're going to talk about a really fast rhythm later. And so when we talk about that, the distinction is that this one is fast, skinny, but it's not so fast that it's faster than 150. So fast, skinny, and less than 150 is a way to remember sinus tachycardia. Everything's normal. It's just a little faster than normal. So let's talk about what you're going to do about sinus tachycardia. Again, you're going to look at, is the patient stable? What's their blood pressure? Are they having any symptoms? If they are stable, we're going to do the same thing. We're going to monitor them, maybe ask what their normal is. What's their normal heart rate? Maybe it runs a little bit fast. We can also maybe consider some causes: dehydration, fever, pain. If the patient's unstable, then we want to start looking at treating that rhythm. So we talked about in a slow rhythm how it's not good because you're not getting enough heartbeats to get enough blood out. So you're not getting that oxygen, that blood out to your tissues. Well, this seems like the opposite. Shouldn't this be good if your heart's beating really fast? Well, it's not. If your heart's beating too fast, it doesn't have time to fill up. So even despite beating faster, it's not filling up with anything. So you were just pretty much pushing out little bits of blood at a time. It's still not going to get enough perfusion. It's still not going to get enough oxygen, and your tissues are going to be hungry. So we want to slow that rhythm down so that your heart has time to fill. So how can we slow it down? We can slow it down with beta blockers. Remember, this rhythm is mostly normal. We just need to slow down the rate a little bit. So one option is beta blockers. And then we might also just treat those causes that we talked about. Fluids, giving them Tylenol, antipyretics, maybe some pain medication if the pain is their problem that's causing their heart rate to be high. All right, so we've talked about most of the normal and the sinus rhythms, so let's start talking about the difference between a top of the heart problem and a bottom of the heart problem. If you'll remember that when we're looking at a rhythm, there's P waves and then there's QRSs. The P wave is telling us what's when there is the top of the heart is squeezing, whereas the QRS is telling us when the bottom of the heart is squeezing. And this is really important when you're doing these rhythm interpretations because you can tell where the problem is by seeing, what is abnormal. So when we're talking about top of the heart problems, we're going to look at the P waves. If there's a top of the heart problem or an atrial problem, there's going to be a problem in the P wave because remember, the P wave tells us if the top of the heart has squeezed. And if there's a problem with the top of the heart squeezing, it's not doing its job, something's off. If something's off with the P wave, that's telling you have an atrial rhythm. That can help you differentiate and kind of break down, and tell the difference between a atrial rhythm and a ventricular rhythm. Excuse me. So let's talk about AFib or atrial fibrillation. If you had to nickname this rhythm, you could call it regularly irregular, and we'll go more into that about why it has that name. So in this rhythm, there are P waves, yes, but are they normal? No, because remember, when we're looking at top of the heart problems, or we're looking for P wave problems. So atrial fibrillation is the top of the heart problem, so therefore it's a problem with the P waves. So can you see a P wave in this rhythm? If you can, I'll give you $100 if you can tell me one normal P wave. There's not a normal P wave in this rhythm. All of the waves there are fibrillatory. So what this is telling us is the top of the heart is fibrillating. It's not contracting. It's literally just quivering. So that's what produces these crazy waves that look like a toddler just kind of drawing across the screen. The other thing that's different about it is it's regularly irregular. This is where it gets its name. So you can see here, the top of the heart is kind of randomly quivering. So the bottom of the heart, it's not in sync with the bottom of the heart. So you can see here, where that, remember a regular rhythm is that that steady beat. This one's kind of like, it's that irregularity. And the thing about it, when I say regularly irregular, which means you can count on it being irregular. Every 2 beats. Every beat is going to have a different distance from the last beat. So you can see, even looking at this rhythm, those QRSs, they all have different distances from each other. So it's regularly irregular. It's going to be one of the few rhythms that you're going to need to understand, these basic rhythms, that is irregular. You can see, though, one thing you can count on is your QRS. It's present and skinny, because remember, the QRS is telling us about the bottom of the heart. Do we have a problem with the bottom of our heart in this rhythm? No, the bottom of our heart is fine. It's that darn top of the heart that's fibrillating. So there's no problem with your QRS. It's present, it's skinny. A rate in atrial fibrillation can be slow, it can be normal, or it can be fast. So it can be a slow AFib, it can be AFib with a controlled rate, or it can be AFib with RVR, which is a very fast rate. Most of the time you're going to see it be normal or fast. So what are we going to do about atrial fibrillation? So let's back up and think about this rhythm. So the top of the heart is fibrillating. So in other words, it's just quivering. So what does that mean for the patient? That means if the top of the heart is quivering, they're not getting as much blood from the top of the heart to the bottom of the heart. If there's not as much blood getting from the top of the heart to the bottom of the heart, that means the bottom of the heart doesn't have as much blood to get out to the lungs to get oxygen. It doesn't have as much blood to push out to the rest of the body to deliver oxygen to the tissues. So what does this mean? This means this patient is usually hypotensive. If they're going to experience a symptom, one of the biggest things we worry about is that their blood pressure is going to drop. They're not going to have the same volume getting out of their heart because the top of the heart is quivering. So the other thing we worry about is if the top of the heart is quivering and it's not sending blood from the top to the bottom, where is that blood going? It's pooling, or it's staying in the atria. So now we have this stasis of blood in the top of the heart. And why do we care about that? Well, stasis of blood means risk for blood clots. So our two biggest concerns for this patient are going to be hypotension and risk for blood clots. Because what's going to happen if they get a blood clot in the heart? Eventually that blood clot is going to be pushed forward, and where does it have to go? It can either go to the lungs, cause a pulmonary embolism, death, or it can go out to the body, cause an MI, a heart attack, or it can go to the brain and cause a stroke and death. Again, all these death things that can happen. So blood clots are no joke, and if they're in the heart, they can go anywhere in the body, and your heart's just spewing them out. So it is so important that we get these patients right under control and try to get them in a normal rhythm, because they are such a high risk for blood clots. So anyway, let's get back to our scenario. So, patients in atrial fibrillation, what are we going to do? We're going to first, of course, assess, is the patient stable? So what is their blood pressure? Well, a lot of patients are going to be hypotensive. Not all people are. So we want to see how their body's tolerating it. How do they feel? Are they dizzy? Are they lightheaded? Are they short of breath? If they're not experiencing any of that, we're going to monitor them. We're going to compare it to their baseline. Maybe this is their normal rhythm. And then we're going to maybe consider other possible causes like an electrolyte imbalance or heart disease. But no matter what, even if the patient's stable, even if they feel wonderful, they feel like running a marathon, we are still going to need to put them on anticoagulation. Every patient in atrial fibrillation must be on anticoagulation unless it's contraindicated. If they are not, they are so high risk for a blood clot. So anytime you have a patient in AFib, they should be on some sort of anticoagulation. So that's warfarin, that's heparin, low molecular weight heparin, or apixaban, all of those, dabigatran, all those new age, one of those medications that just should be on some sort of anticoagulation. So what if the patient's unstable? So if we go in there and their blood pressure's low, or they're feeling dizzy, lightheaded, short of breath, feeling palpitations, then we're going to consider our ABCDs. So we might give them amiodarone, beta blockers, calcium channel blockers, or digoxin. So beta blockers can be used to help slow that rate down. Beta blockers are not going to get you back to a normal rhythm, but beta blockers, if you're going super fast, if you have a super fast rate, they can help bring down that heart rate so that your body can remember what's the problem with a really fast rate is that you can't fill. So by slowing it down, we're giving them a better chance of filling to get better cardiac output and therefore better perfusion to the rest of the body. Our goal, though, even though we like to slow down this rhythm to a normal rate, our goal more than anything is to get back to normal sinus rhythm. So how can we do that? We can use drugs such as amiodarone, calcium channel blockers, and digoxin. These drugs also will slow down the heart rate, but they'll also have the capability to convert you back to a normal rhythm. If those drugs aren't effective or if the patient's very unstable, we might also consider other treatments like cardioversion and oxygen to support their oxygenation needs. So let's talk a little bit about the difference between cardioversion and defibrillation. So cardioversion is for a patient who has a pulse. That is the biggest difference between cardioversion and defibrillation. Cardioversion, they have a pulse. We're going to use a little bit of electrical activity to kind of boo, surprise, shock their heart back into a normal rhythm. But this patient must still have a pulse in order to be cardioverted. Now let's look at atrial flutter. Atrial flutter is atrial fibrillation's brother, and it has a nickname of sawtooth regular. Oh, let's see why it has this name. Again, we have a top of the heart problem, an atrial problem, so there's going to be something weird about the P waves. So if you look at this rhythm, there are flutter waves. They're called flutter waves. Sometimes they're called sawtooth waves. But no matter what, this is not normal. Now you may be looking at this and you've never seen this rhythm before. You're like, hey, it looks normal to me. There's a little hill thing. But does it look like those other P waves we've been looking at? No, it's not rounded. It's pointy. So it's that sawtooth or that flutter, kind of the, some people call it like a butterfly, wings kind of shape. So, despite the fact that there is some sort of wave there, it's not normal. It doesn't look like that normal small hill before the QRS. The thing you'll notice that's different between this and AFib is going to be, is this regular? Yes, look at it. The distance between each heartbeat is normal. It's at least more regular than AFib is. So this is one of the things that differentiates A-flutter from AFib, is that it's more regular and it has those pointy waves. Remember, in atrial fibrillation, they have the fibrillatory waves. It's kind of that chaotic. It looks like a 2-year-old drawing across a piece of paper. Whereas this is much more organized. You can actually kind of see waves. They're not a normal wave, but they look a lot better than those fibrillatory waves. Does this mean this rhythm is more stable? Not necessarily. It's just prettier. It's nicer to look at for sure. Again, the QRS is going to be present and skinny because we don't have a bottom of the heart problem. We don't have a ventricular problem. We have a atrial problem, a P wave problem, a top of the heart problem. The rate, again, can be slow, normal, or fast. So what are we going to do for this patient? Again, the exact same thing. This rhythm looks a little different, but it's the same problem. We want to make sure, our goal for a patient in AFib or a flutter is to convert them. If we can't convert them, we want to bring that rate down to a stable rate so that their heart has the best chance of getting adequate cardiac output. It's all about that tissue perfusion. So if they're stable, we're going to monitor them, of course, compared to baseline. What's their normal rhythm and rate? Think about possibilities in electrolyte imbalances or heart disease, and make sure that they're on anticoagulation. If they're unstable, we'll do our ABCDs. Maybe think about some cardioversion and oxygen, excuse me, to make sure that we can get them back to a normal tissue perfusion. Remember, it's all about getting oxygen to your tissues. So, now we have supraventricular tachycardia. So this one's name is fast and skinny greater than 150. So when you're looking at supraventricular, you're thinking, oh, we're in ventricle rhythms now. No, look at the name though, supraventricular. Supra means above. So if we are above the ventricles, we are still in the atria. So we are still looking for a problem with the P waves. We are not worrying about the QRS. It's all about the P waves still. So let's look at them. So the P waves, where are they? Well, they're somewhere in there probably, but they're hiding. We are unable to see them. This rhythm is so fast. Remember when we talked about sinus tachycardia, I said it's, it's less than 150, or up until 150. This is supraventricular tachycardia. It's super, super fast. So this rhythm is going so fast that if there are P waves present, we can't see them because they are buried deep within that, fast rhythm. So again, this is a P wave problem. P waves are missing. We cannot see the P waves. You may be wondering, that little hill that you're seeing in this rhythm, that's a T wave. It's coming right after. It's attached to the tail of that QRS. It is not to itself. P waves are all by themselves and a little distance from the QRS. So in this rhythm, again, it's a P problem. It's a top of the heart problem. P waves are missing. The regularity, it's very regular. The QRS, it's present, and again, it's skinny because we don't have a bottom of the heart problem. We have a top of the heart problem. And our rate is going to be super fast at a rate of greater than 150. So to sum up, we are fast and skinny and greater than 150. So what are we going to do for a patient in supraventricular tachycardia? We want to see, is the patient stable? As always, what's their symptoms are they experiencing? What's their blood pressure? If they're stable and they're looking at you like you're crazy, like, oh, I'm fine, do we just leave them alone? Nope, we still got to do something about it. We're going to ask them to do a vagal maneuver, a Valsalva maneuver. This is where they bear down, push really hard to try to get back to a normal rhythm. Sometimes that pressure, even blowing into a straw into a cup of water, can do the same effect as these vagal or Valsalva maneuvers. If the patient's unstable, so if their blood pressure's low, if they're dizzy, having palpitations, feeling weak, fatigued, short of breath, then we're going to consider drugs or other treatments. So the drug we would be using is possibly adenosine, and I remember adenosine because DEN, it discontinues the electrical node. So that's our first choice. And this is a drug that's really specific to the supraventricular tachycardia. There's other drugs we can use, but usually this is going to be the most common one. And adenosine, the reason it got its name of discontinuing the electrical node is this is your on and off switch. Adenosine can be used to actually stop the heart. When it's given correctly, give it super fast, you push it in fast IV, it actually stops the heart. And when the heart restarts, we hope that it restarts in a normal rhythm. Other possible treatments, because this is a fast rhythm, is cardioversion or oxygen. We want to make sure that they're getting oxygen to their tissue, so we may need to give them that supplemental. But a lot of times, if the adenosine's not working, if they've tried to bear down and do the vagal and Valsalva, it's still not working, then we'll cardiovert them, especially if they're incredibly unstable. And you'll see we've gotten at a point in the rhythms where, despite the fact that the patient may be stable, we still got to do something about it. If a patient has a heart rate greater than 150, we can't just sit around and leave them to their own devices. We need to do something about this rhythm because at some point their heart's going to tire. At some point they're not going to be getting adequate tissue perfusion. So we need to do something no matter what. All right, you survived top of the heart problems. Now we're going to bottom of the heart problems. So up until now, we've been focusing solely on the P waves. All about those P waves, there was a problem. But now we're going to bottom of the heart problems. So P waves are no longer the issue. We may not be able to see them. The big problem is there's going to be something different about our QRS. Remember, so far our QRS has been really skinny because skinny is normal. However, when we start going into these ventricular rhythms, we're going to note that our QRS is now going to become wide, fat, abnormal, bizarre. Something's going to be off. So let's start looking at those QRSs. Our first ventricular rhythm, or bottom of the heart rhythm, is going to be ventricular tachycardia. So let's look at this. P waves, none that can be seen. So that seems a little off, but let's keep looking at this. Regularity. Well, it looks pretty regular. If you look at the distance between each beat, it seems like it's about the same distance from each other. But wait, what's the weird thing about this one? Look at that QRS. Remember, we're in a ventricular rhythm. Something's wrong with the bottom of the heart. If you see some wide, bizarre QRSs, you have a ventricular problem. And luckily, there's only really 2 ventricular rhythms you need to know. So helps to narrow it down. So we'll talk about the difference between the 2 of them, but let's look at this one. So this one, it's regular, it's wide, and bizarre. So that's if you had to name ventricular tachycardia, it could be regular, wide, and bizarre. The rate's usually going to be very fast as well. So what differentiates this from all the other rhythms that we looked at? Well, there's no P waves, but that's because we have something much bigger going on. Our ventricles have taken over and they are beating super fast. Remember before when we were talking about supraventricular tachycardia, it was so fast you couldn't see the P waves. Well, this is what's happening again, except the big difference. Remember, the differentiation between atrial and ventricular problems is that QRS. In supraventricular tachycardia, what was your QRS? It was skinny. Look at this rhythm. Is there a skinny QRS to be seen? No. It's wide, it's crazy, it's bizarre. The rhythm itself seems pretty regular and uniform, but it's so wide, something's not right. So we know we have a ventricular problem, a bottom of the heart problem, a ventricular tachycardia problem when we have a fast, wide, and bizarre regular rhythm. So yes, I know that's a lot to take in, but let's talk about what we're going to do about this, and then let's look at the other ventricular rhythm, and once we start to compare, it'll make more sense. So what are we going to do about ventricular tachycardia? Well, there's 2 types of VTAC. There's VTAC with a pulse and VTAC without a pulse. So what are we going to do first? Check for a pulse. So if the patient has a pulse, we're going to consider drugs like beta blockers, which can help to slow that rhythm down, or we can use amiodarone, which can slow it down or convert it. I always remember amiodarone, that amio can make it slow. So amio can make it slow, but it also can convert it back to a normal rhythm. If drugs aren't effective, we might also consider cardioversion, give them that baby shock to get them back to a normal rhythm. What if you go in, though, and there's no pulse? What are we going to do? If there's no pulse, what do you know to do? CPR. We're going to start CPR, and we want to defibrillate as soon as possible. It used to be that the guidelines said that we want to do 2 minutes of CPR, the 5 rounds before we defibrillate. But now current guidelines actually say to defibrillate as soon as possible. So that means you're not going to delay CPR to wait on a defibrillator, but as soon as that defibrillator becomes available, you want to put it on that patient and give them that full shock, defibrillation. Remember, I told you there's a difference between defibrillation and cardioversion. Defibrillation has a D for death, which means this patient does not have a pulse. So when we defib, we are trying to, excuse my language, sorry. We are trying to completely restart the heart. And so that's the big difference, in that power between cardioversion and defibrillation. Cardioversion, we're just trying to give a little, kind of a scare, like boo, like, kind of get a restart to it. Whereas defibrillation, we are completely trying to recharge the heart, get it reworking again. So for this patient that has no pulse, like I mentioned, CPR, get those pads on them as soon as possible, get them shocked, and then we might use medications like epinephrine, amiodarone, magnesium. A lot of ventricular tachycardia can be caused from electrolyte imbalances, so we always want to consider those as well when we're treating this rhythm. So remember I said we were going to compare ventricular tachycardia to ventricular fibrillation. So let's break this one down. Ventricular fibrillation, P waves. Do you see any P waves? Nope, I don't know what the heck's going on here. Let's keep going. Regularity? There's nothing regular about this rhythm. It's just crazy. It looks like a scribble. QRS? I don't even know what the heck the QRS is, but it's something wide and it's even more bizarre than the last one. Rate? I cannot even calculate the rate, but it looks like something crazy is going on. So ventricular fibrillation, unlike ventricular tachycardia that was regular, fast, and wide, this one is irregular. Lord knows what the rate is, and I believe it looks kind of wide. I don't know. It's really hard to tell what's going on. The difference between VFib and VTach is VFib, you can barely tell what's going on. It's just a squiggle. Ventricular tachycardia is much more organized. It's usually regular. It has that wide QRS, but you can see like some semblance of a rhythm. In ventricular fibrillation, you don't know what the heck's going on. There's just this random scribble. Now, I know as a new, person learning EKG, you may look at all of these rhythms and just say that they look like scribbles. But this one really just looks like, some sort of up and down scribble. There's nothing discernible in ventricular fibrillation, and that's really what's going to differentiate it from others. Because what's actually happening? There is nothing going on. The bottom of the heart is fibrillating. So why does that matter? Well, the bottom of the heart's the one that's responsible to get blood to the rest of your body. And if the bottom of your heart's fibrillating, that means you're getting zero, none, nada, not an ounce of blood out to the rest of your body. And if you're not getting a single ounce of blood out to the rest of your body, how is it going to function? It's got no oxygen, it's got no perfusion, so therefore, you're in this dead state. Ventricular fibrillation is not compatible with life. So what are we going to do for a patient in ventricular fibrillation? Well, of course, we're still going to check for a pulse because we always want to, kind of check that first. And I got to tell you something. Ventricular fibrillation, like I said, is not compatible with life. If it actually is VFib, there will be no pulse. There is no VFib with a pulse. There's a VTach with a pulse, but there's no VFib with a pulse. So what did we decide that we do when there's no pulse? Well, we start CPR and we get that defibrillator and we get them shocked as soon as possible. We have our drug options to give epinephrine and amiodarone, but we really focus on that high quality CPR and getting them shocked as soon as possible. Those are our priorities, especially getting that shock as soon as possible. That's why they say defib for VFib, because the sooner we shock them, the sooner the better chance that they have at restoring their circulation and getting their heart restarted. So these are just the basic rhythms. I know that it might be overwhelming. Hopefully this didn't confuse you more than you already were confused, but hopefully this will just break them down a little bit. Feel free to ask questions and send me an email if there's anything that you're still confused about. Just be gentle with yourself. These rhythms are hard. If you've never done this before, it's like looking at crazy children's artwork. It does get better. Keep practicing. Keep being systematic about it. And you're going to do fabulous. Thank you for listening.